You are called to a 67-year-old male patient that is in cardiac arrest. The fire department says that they have CPR in progress, and you arrive shortly after. And you find the patient is complaining of chest pain for about 2 hours and then suddenly collapsed, and his wife called the ambulance. You put him on the monitor and you find him in this rhythm. Once you see that they're in this rhythm, you shock them and notice that you get a pulse back. You do a set of vitals, and this is what you get. Now that you've had ROSC, what do you need to do in order to keep this patient from going into cardiac arrest again? Based on the vitals, what treatment would you like to start to keep them from arresting again? Go ahead and put your answers in the comments, and we're going to break this case down later today.
Hey everyone, I'm Dean with Master Medics. Thanks for tuning into the video. Today I want to go over a case. Specifically, I want to go over a case of ROSC. If you don't know, ROSC stands for return of spontaneous circulation. Basically, you get pulses back on a cardiac arrest patient. If you're anything like me, you ran like 50 million mega codes in school or an ACLS or whatever. And you can treat all the rhythms, you know, all the drugs to give, etc. And then the mannequin either dies, or your instructor complains, or every once in a while you get pulses back and the mega code ends with basically saying something along the lines of, I would give fluid, consider a vasopressor, a pain 12 lead, etc. And it's over. We learn a lot about managing codes. What we don't learn a lot about is what to do when you get someone back. And that's kind of what I want to focus on today. So let's say you and your partner are sent to a private residence for a 67-year-old guy with chest pain. The fire department gets there before you, and they update that CPR is in progress. So you get on scene and you find the patient with CPR ongoing. Basically, he has been complaining of chest pain for the last 2 or 3 hours while at home with his wife. She tried to convince him to call 911 since the beginning, but he didn't really want to. He has a history of GERD and kind of basically just thought it would go away. It was kind of thinking it was his GERD, but it didn't, right? So about 15 minutes ago, he went to go take out the trash. His wife kind of heard him collapse in the garage, and she called 911. So the fire department got there pretty quickly and actually witnessed the arrest, and they shocked once with their AED. So you get there and you put the patient on the monitor and you see this. So, first question, what's this rhythm? It's VFib, right? And ultimately you shock it 3 times. You give some epi, you give some amiodarone, and you manage the airway BLS. Then on your next rhythm check, you get pulses back. So now what? Over 500,000 Americans die annually from sudden cardiac arrest. Around out of these, roughly 2/3 are out of hospital cardiac arrest, and about half of those end up being workable at the time by EMS. Of those, about a quarter will have ROSC and survive at least the first hour of their ER stay. Unfortunately, only around 11% of these patients actually survive to discharge, and only around 8% will survive to discharge neurologically intact. EMS has kind of made great strides in recent years to improve these numbers. PIT crew CPR, early defib, focus on compressions, good BLS, etc. All have helped to get these patients back. But I think there's kind of a hole after that. So again, right, you get them back. Now what? Turns out the next 10 to 20 minutes are super important. The most immediate threat to survival during the first few minutes to hours is cardiovascular collapse, right? So roughly 4 out of 10, or almost half of these patients will rearrest within the first hour of care. So if you think about it, these are kind of the sickest patients you'll manage in the back of your ambulance, and your decisions during this time could mean life or death for this patient. So let's jump back into the case and talk about some of these decisions. So you perform a basic assessment. His pupils are fixed and dilated. He has no motor response to pain. His heart rate's 112. His blood pressure is 75/40. So what's kind of happening here? Basically, this guy is suffering from what we call post-ROSC syndrome. So what is post-ROSC syndrome? Basically, it's hypoxia, ischemia, and reperfusion injury that occur after resuscitation, and it results in damage to multiple organ systems, specifically the cardiovascular and kind of neuro systems, basically irrespective of the precipitating event. I like to think of it as the four horsemen of the post-arrest apocalypse, right? You have systemic ischemia and reperfusion response. You have myocardial dysfunction, post-arrest cardiac or post-cardiac arrest brain injury. Sorry, and finally, the persisting precipitating pathology, right? So the severity of these manifestations will vary with each patient. And when ROSC is achieved rapidly, the post cardiac arrest syndrome can be kind of limited or even absent. Basically, prolonged cardiac arrest can result in post cardiac arrest syndrome, kind of refractory to all interventions. So, fortunately, each component of these, however, is potentially treatable and reversible. So, I don't want to go crazy with pathology here, but I want to focus more on the treatment. So we'll go over the basics real quick, though. Basically, systemic ischemia and reperfusion response is so there's a whole kind of bunch of pathways involved here. So we get this systemic inflammation, endothelia activation, kind of this profound immunological response, and then some adrenal suppression. And there can be kind of some wonky stuff with coagulation also. Basically, what you end up getting is a septic shock like picture, which coincidentally also increases the patient's susceptibility to infection kind of in and of itself. Next, you have myocardial dysfunction. Basically, you get hypokinesia of the cardiac muscle. It's kind of like a myocardial stunning. It's associated with a reduction of left ventricular ejection fraction, and it's kind of most common in the first 24 to 48 hours or so. And that's actually even if the patient didn't already have heart problems, like it's a problem in and of itself, right? So even if the patient didn't have any heart problems leading to the arrest, like an MI, this is still seen in like other kinds of arrests. Basically, it occurs despite adequate coronary blood flow, right? So it doesn't necessarily mean that the heart is suffering or that the heart's not oxygenating enough. There, you could have clean coronaries and still have this happen. It usually manifests as kind of like a tachycardia, hypotension, and then a left end diastolic dysfunction, so like a heart failure kind of a picture. Um, so basically, they take a cardiac output hit, and oftentimes it kind of gets worse before it gets better. Basically, it's like a cardiogenic shock. And then you get this, which is post cardiac arrest brain injury. This is actually the number one cause of death post resuscitation. So 68% of post arrest patients in the ICU will ultimately die of some form of neuro complication. The brain has absolutely no tolerance for ischemia, as we know. So brain injury after ischemia is kind of this active process that develops in successive phases over the course of like hours to days post arrest. So there's a whole bunch of mechanisms that contribute to this form of, from like I don't know, energy failure, loss of ion gradients, um, reperfusion injury, edema, radical oxygen species during the reperfusion, a whole bunch of stuff. Kind of the big goal here is preventing secondary brain injury, right? Because the initial insults happened. We're going to try to prevent like all the secondary problems like hypoxia, hypoperfusion, that kind of stuff. Basically, post-stress brain injury is characterized by failure of autoregulation of the brain, which leads to ultimately cerebral hypoperfusion, ongoing kind of ischemia, and then you can get some additional oxidative injuries, cerebral edema, seizure, hyperpyrexia, but a bunch of problems can come with this. And honestly, it's very similar to a TBI patient, right? It's like a really bad TBI patient, and that's kind of the way I like to think about it. So basically, in this post-arrest syndrome, in this one patient, we have sepsis, cardiogenic shock, and a severe TBI all at once. And then to top it all off, you have to think about the precipitating event, right? So something made them arrest, and that can still be a problem, right? Like this guy was complaining of chest pain, right? Does he have a massive MI, a big PE? Could there be forms of respiratory failure, electrolyte imbalances, toxicology issues, whatever it be? Turns out your resuscitation, like your epis and your intubation, generally don't fix this problem. So on top of this, like cardiogenic, septic-y, severe TBI picture, you also have whatever made them arrest to begin with still going on. So these patients are super sick. So let's talk, treatment. And we'll kind of talk about it from an ABC format just to kind of keep it organized, but know that a lot of this stuff kind of happens concomitantly. So we'll start with A and B first. So This guy's unresponsive with fixed and dilated pupils and has an unsecured BLS airway. Don't get hung up on the fixed and dilated pupils part. So actually, fixed and dilated pupils aren't considered diagnostic for true brain death until 72 hours afterwards. So you can have fixed and dilated pupils for the first couple of days and still recover neurologically intact. I think that's a common misconception that we get. But basically, the guy's unresponsive and he's kind of got a crappy airway, or at least a BLS airway. So the real question is, would you intubate this guy? And it's kind of a tough decision. So I would say yes, right? The patient should be intubated. They're obtunded, they have essentially a big TBI, and you can probably justify intubating them all day. However, I wouldn't do it right now, and that's the big thing. They're way too unstable right now, and the procedure would probably kill them. So yes, at the end of the day, they need an intubation, but we can do it safely in other means, maybe later on after we resuscitate them a bit. So his heart rate is 112, and then their systolic blood pressure is only 75, right? And this gives them a positive shock index of 1.5. So basically, anything greater than 0.9 is considered an independent risk factor for death after induction of RSI. So that blood pressure alone should tell you that this patient needs to be resuscitated first. So yeah, they need a tube, but like we need to fix them first. And remember, we never intubate alive patients without meds. So just going for it, even if the patient's unresponsive, isn't the answer either. I've done a whole other video and a couple Facebook posts and stuff on that, so check it out. Basically, alive patients should get meds. So for now, we can keep managing this airway BLS with the plan to intubate soon. He was being ventilated during the arrest. So does he still need that? Kind of reassessing that picture. So if not, we can pre-oxygenate with a non-rebreather and a nasal cannula, and then kind of start to get ready for inevitable intubation. Start having that like nitrogen washout and that kind of stuff there. So we can kind of start heading that direction. Or if we need to, we can keep bagging them. So let's say he is actually breathing on his own. We don't need to ventilate him anymore. What flow rate should you set your nasal cannula for pre or apneic oxygenation? 15 liters per minute, ideally, right? This will help keep that O2 concentration gradient that we need during the apnea phase with that apneic oxygenation with the nasal cannula. So, though we aren't going to technically intubate right now, we still have to have that plan, right? There's a misconception when it's talked about nasal cannulas with using like the end-tidal cannula, etc. It turns out end-tidal cannulas are actually limited with their flow. You can go like 4 to 6, but you can't really go any higher than that. A standard nasal cannula at 15 liters per minute flush rate is actually a pretty good way to pre-oxygenate or apneic oxygenate someone. So, what meds and doses are needed for this intubation, or what meds and doses would you use? So, I would use either ketamine or etomidate. Both are pretty safe when it comes to hypotensive patients. The key is kind of reducing the dose. So it's less so an agent problem, right? Both of them can cause hypotension, especially in a shocked patient. Ketamine doesn't, cause that adrenergic kind of response that we think it does, especially in someone with shock. So either of these has actually been demonstrated to be pretty safe. You can use whichever one. The big key is reducing the dose of them, right? So I usually drop the standard dosing, so like 1 to 2 milligrams per kilogram for ketamine, 0.3 milligrams per kilogram for etomidate. And what I do is I'll give like half or sometimes even a quarter at a time and kind of wait for induction and then push the paralytic. Something like, so if we're going to use ketamine, for example, 0.5 milligrams per kilogram of ketamine at a time. So there's little kind of quarter bits at a time until they're out, and then I'll push the rock. That way we only use as much as we need to and reduce the chance of post-intubation hypotension. When it comes to a paralytic choice, I like rock. I'm kind of biased towards it. I always choose rock. And then the dose I use is usually 1.5 milligrams per kilogram. Obviously, follow your local stuff. If you use a different dose, that's fine. But here, arguments can be made that in shock patients, you should actually go up on your paralytic dose. So that's something to consider too. All right. So moving on to circulation. This is a big one here. And the patient's super shocked. So they have kind of three jams from a circulatory perspective. One, they have this septic-like state with profound vasodilation, third spacing, and all of that. Two, they have that myocardial stunning going on. And then three, let's keep in mind that they had chest pain before he went down, and in a VFib arrest when we got there, right? So we need to think about kind of an MI here. So this patient's tachycardic, hypotensive, and just had an arrhythmia. So kind of let's start basic first, right? Should we give this guy fluid? And if so, how much should we give? So how much fluid would you give this guy? So I'd say we should give them fluid, right? Most post-ROSC patients are preload responsive and tolerate moderate volumes of fluid. So I'll usually start 2 IVs and slam with 5 liters. No, right? That's not what I'm talking about when we say fluid. I like to give like 250, 500 ml boluses at a time and then kind of reassess after each. Now, if the patient's like a known heart failure, edema, or like a renal failure patient or anything like that, it's okay to use a more kind of restrictive strategy. But this guy doesn't have much to that, so we can give him a little bit. I would probably start with 500 and then kind of go 250 at a time after that. And then usually my practice is to do like, I don't know, usually a liter or so before I start to like consider if this isn't worth it or not. So, if you're going to give those boluses, how quickly should you get those in? Again, big misconception here. When we talk about boluses and fluid, you want to give them really rapidly. And I like to use a pressure bag to do that. This isn't something I'm just going to hang and like hope it goes in over the next 15 minutes. This is something that we want to squeeze in quickly. A bolus isn't hanging up and watch it drip. It's a fast flush, right? I want 500 mLs or so over the next like 5 minutes, right? And pressure bags are your friend here, right? Use them. I use them all the time. I love pressure bags. So again, I'll usually go like a liter or so, depending on how far away I am from the hospital and kind of reassess from there. But I'll do like 500, 250 to get there. So, when would you add a vasopressor? And here is kind of a controversial question, right? When would you add a vasopressor? For me, I like to be aggressive. I add one basically right away. Right, if the blood pressure is like 88 over 64, sure, you can try some fluid first or something, but like 75 over 40, I'm going to hang it in parallel, right? So I'm going to hang my fluid and then hang a pressor like almost immediately afterwards, essentially together. If the patient's fluid responsive and rebounds well with the fluid, fantastic. We can wean our pressor down pretty quickly. But now at least it's there and we're getting it on board early. I'm not gonna let the patient sit there like that while I give them like a basically internal bath with some saline before I'm like, oh, I should give them something to squeeze the tank. No, no. Fill the tank, give some squeeze at the same time. I like to use both at once. So, with that in mind, what would your first line vasopressor be? It's kind of a controversial question sometimes. So, technically, there's no data supporting a particular vasopressor over another in the setting of post-arrest patients. Um, you know, from data kind of extrapolated from other relevant studies, norepi is generally preferred as like an initial agent for most cases, and it's usually really well tolerated. Usually, I reach for norepi first, and then I'll kind of figure out what's going on afterwards. So, if you don't have norepi, epi is probably not a bad choice, and would probably be my second choice. Generally, I would want to avoid dopamine due to the higher risk of tachyarrhythmia, especially the fact that they already had an arrhythmia during their arrest. We don't want to kind of, upset an already angry heart. So now we're working on some preload, working on some afterload, and a little bit of contractility. What else can we kind of be thinking about here? Well, they had that arrhythmia, right? The patient was in a shockable rhythm, VFib specifically, and maybe even like a VTAC at first. We don't actually know because the initial rhythm was shocked by an AD, so it could have been a VTAC. We don't know, but we definitely witnessed VFib. So we gave an amulode during the arrest, the standard like 300 milligrams or whatever. Do we want to add an infusion now that we have ROSC? So another question, right? Would you add an infusion or a second dose of an antiarrhythmic? To be honest, you're going to hear conflicting things here, but you don't actually need to. You can if you want, if your protocol warrants it, but you don't have to. Generally speaking, I won't add an antiarrhythmic infusion post arrest unless I need to. And what's my trigger point for that? Basically, another arrhythmia. Acutely, the patient should be treated for like the standard like ACLS kind of answers, and then I'll add an infusion afterwards if I need to. My go-to is usually amio first, but Lido's fine too. The important part here is that there's no evidence to support the use of prophylactic antiarrhythmic infusions in the post-arrest patient, so you don't actually need to. So now let's talk about 12 leads, right? When should you get a 12 lead on this patient? Generally speaking, I'll wait, right? So ACS, sorry, is the most common cause of sudden cardiac arrest. You should always repeat a 12 lead after ROSC. However, there's a debate as to kind of when to do that, right? Is it immediately? Is it a few minutes later? Um, you know, Basically 96% of post-arrest patients who have a ST elevation will have a significant lesion. However, you can have early ST elevations beforehand that go away. So obviously we need to look for STEMI, but we need to keep other things in mind too, right? You can have like abnormalities of conduction intervals. You can have electrical axis problems. You can get T waves that are all kind of weird, and they can all provide clues in kind of the etiology of that arrest. But it's important to keep in mind that that false positive rate for ECGs and the diagnosis of STEMI is kind of time dependent. So that false positive rate for ECG for a STEMI most commonly occurs within the first 7 minutes of ROSC, which is why I wait that 7 to 10 minute mark to start doing my 12 lead, right? So we minimize that chance of a false positive. Or if you're going to do one immediately, do one at least 10 minutes later and compare the two, right? Um, that early kind of problem is usually due to transient myocardial ischemia from like a global hypoperfusion that happened during the arrest. And then you also kind of just gave them a big dump of epi right during the code. So it's probably something to do with that as well. But because of this, I usually wait around 10 minutes to perform one. So you can wait and get one. All right. So is this patient having a STEMI? So let's take a look at their EKG. This is obviously a representative EKG, but we'll say this is their 12 lead post arrest. Hopefully you guys see the gigantic anterior lateral wall MI, right? They're basically their entire precordial leads are up, and then you have V1, AVL, get some depressions, 2-3 AVF, V1 through essentially V6 is up. Tombstoning, basically, he's got a massive MI. So should you give this guy aspirin? So the patient's having a STEMI, right? Just because he's post-rest now doesn't mean you can forget your STEMI treatments, right? So aspirin's important, and if it's within your scope, you can give it crushed through an OG tube, you can give it rectally, right? You can, just because you can't chew doesn't mean you don't have to give it. Obviously, I understand this may not be within your scope and will vary from kind of place to place, but something to consider. Okay, cool. So let's say we did all of that, right? His mental status hasn't changed. He didn't need the BVM anymore. He's kind of spontaneously breathing. Um, he remained unresponsive. He's being pre-oxygenated with an underbreather nasal cannula. Both are at 15 liters per minute. He's got a respiratory rate of like 24, SAT of 100% at this point. You gave 2 fluid boluses for a total of a liter or 3, depending on how you split it up. And you started norepi and are titrating that, using your standard dosing and titrations based on your local protocols. So now his heart rate is 110 and his blood pressure is improved to 102/60. So are you okay with that blood pressure? So, what are your blood pressure goals for this patient? I think this is important and often overlooked. So, this one can also be kind of controversial. And while technically it's a circulation question, we're going to talk about it in the context of disability because really it's a neuro based answer. So, remember how we said this patient's in cardiogenic shock, right? Septic shock, and then also kind of has a severe TBI. We need to prevent secondary brain injury. And there's really 4 things that we need to do right away. So number one, we need to sit this guy up, right? Put the head of the bed 30 degrees. Not only does this help the intracranial pressure problems, but also, especially in a non-intubated patient so far, it can protect from aspiration and pneumonia as well. So we need the head of bed 30 degrees and the neck midline to allow the appropriate venous drainage. That's step 1, right? So step 2 through 4, we need to prevent hypotension, maintain MAPS, usually greater than 80. We'll get into that in a minute. And we need to prevent hypoxia. We need to prevent hyperthermia. And we'll kind of go through each one of these separately. So, remember how we said this patient is a cardiogenic shock patient, septic shock patient, and a severe TBI patient, right? So let's kind of start with that MAP goal, right? Our general MAP goal for most shocky patients is a MAP of over 60, right? And this maintains renal perfusion and thus kind of should maintain everything else, right? Because the body cuts off the kidneys kind of first, except for we need to remember that this is a TBI patient also. And in post-arrest patients, especially comatose ones, just like in TBI patients, we lose that kind of cerebral autoregulation, right? So our cerebral blood flow, right, becomes pressure dependent. So more on that, you can check out TBI cases, and we've done some videos and stuff in the library, so you can check those ones out. But basically, we need to use pressure to get the blood to the brain. And usually this means a MAP greater than 80 for at least the first 24 hours or so to maintain cerebral perfusion pressure. So, what is the formula for cerebral perfusion pressure? So, cerebral perfusion pressure, or CPP, is equal to the MAP minus the ICP. We assume, kind of in a state of intracranial hypertension, which we assume this patient with a somewhat severe TBI, right, is at least 20, right? And anything greater than 20 sustained is considered intracranial hypertension. So we have to assume it's at least 20. He's comatose. He's got some other things going on. So we're assuming it's 20. And we need a cerebral perfusion pressure of at least 60, ideally 70 to perfuse the brain. So 60 and 20, right, which is where we get that number from, is 80, right? So we have to have a MAP of at least 80 to perfuse the brain appropriately. That's kind of where we get those numbers from. Some sources will keep the MAP goal 65 and say it doesn't matter as much as we think. Some sources will say to target a urine output instead of at least 1 ml per key per hour. The majority that at least I've read still support a MAP greater than 80 as the initial kind of post-arrest period. I tend to kind of agree with that reasoning. So we talked about hypoxia already, and we'll discuss hyperthermia next. And this has to do with targeted temperature management. So this is kind of part of disability, but it's kind of controversial and warrants its own section here. So why is it controversial? Well, it's kind of has to do with three main questions, right? One, what temperature should we actually cool them to? No one really seems to ever agree with this. Two, is it true that hypothermia helps, or is it actually just the avoidance of fever that helps? There's an interesting paper that came out relatively recently about that. And then, should EMS be starting it, or should we wait until we get to the ER? So, starting here, what temperature should we cool to? So the initial trials from 2002, which is really where the targeted temperature management thing kind of kicked off from, they cooled patients to 32 to 34 degrees Celsius. And then in 2013, you had the TTM trial. And the TTM trial cooled patients to 32 to 36 degrees Celsius, or compared patients, I should say, and found no difference between 32 and 36. 32 could come with more complications. 36 was considered equivalent. So now it was, at least 36 degrees. And that was kind of adapted by the AHA in those 2015 guidelines. That's when EMS really started being like, oh, we should be cooling these patients. And we had the Hyperon trial that happened in 2019. Basically, they compared 33 degrees versus 37 degrees. And they found that 33 degrees improved primary outcome, which was basically a favorable neuro outcome. So maybe they should be a little colder. And then in 2021, TTM2 came out, which basically targeted hypothermia versus targeted normothermia after out of hospital cardiac arrest. So this was the first one that kind of looked at, is it more of an avoidance of fever, or is it hypothermia that really counts? Because fever is really, really bad in head injured patients and really bad in post-arrest patients also. Basically, they looked at 33 degrees versus normal thermia with basically early treatment of fever. So essentially what they did was they kept the temperature less than 37.8. So there was no difference in primary outcome or 6-month mortality here, right? Or any secondary neuro outcome. And basically this included patients with non-shockable rhythm, who actually the majority of the patients here were in asystole. It's really the only one that included non-shockable rhythms of like the major trials that happened. So this kind of posed the question, is it hypothermia or is it targeted normothermia and the avoidance of fever that actually ends up helping these patients? We don't really know. A lot more research kind of needs to be done here. But basically the conclusion is that current professional society guidelines recommend actively preventing fever by targeting a temperature of less than 37.5 degrees Celsius for patients who remain comatose after arrest. So basically the patients you're going to consider cooling are patients who are comatose or not following commands after they get ROSC. And basically you can induce hypothermia and at least maintain a lower normothermia and then kind of fever avoidance. And that's kind of the recommendation that everyone's been going with. So you have to keep it at least here, but you can go cooler if you want to. No one really knows. Now, that's all well and good for the hospital, but should we, from an EMS perspective, cool the guy from our case? What should EMS do? So, kind of as a disclaimer, it depends on your system and your local protocols. A lot of hospital systems feel really passionate about this in kind of both ways, but generally speaking, probably not, right? So, now technically, the hospital, right? In the hospital, he meets every criteria for temperature control, and in the ER, they should definitely do it. But you probably shouldn't. Why? Well, one, current guidelines recommend against it, right? Technically, they recommend against the routine initiation of it with cold fluids, which is really the only way we can do it pre-hospital anyway. So kind of blanket statement, maybe we shouldn't be doing it. And there's 2 trials that really looked at this. The first was in 2000, or at least published in 2014 by Kim et al. And basically, they demonstrated that pre-hospital cooling with cold saline didn't lead to any improved survival or neuro outcomes. And it was actually associated with increased rates of pulmonary edema and cardiac arrest. So it might be causing harm. Then the RISE trial came out. I forget when this one was published. I think it was 2016. 2016. And basically it confirmed detrimental effects of that ice saline infusions from the previous study pre-hospitally, right? So early infusion of up to 2 liters of ice saline decreased the chance of survival and ROSC. So kind of the recommendations tend to be for rapid transport and then cooling upon arrival to the hospital. So we gave this guy some more fluid. We initiated some norepinephrine and are titrating to a MAP greater than 80 for cerebral perfusion. We are not actively cooling them, but at the same time, we're not really keeping them warm either. We're kind of aiming to avoid fever because we know that's important. And now that the blood pressure is better, we perform a hemodynamically neutral RSI, and the patient was intubated without incident. And then upon arrival to the ER, the patient was turned over to the team and sent to the ICU a few days later, or a few hours later, sorry. And then again, in post-COVID world, who knows? All right, so, we kind of hit our time here, so we'll cut it off right there. Thanks for checking out the case. If you have any questions, feel free to let me know in the comments, and I'll kind of try to respond from there. Sorry I couldn't do this one live. I was ended up having to work today, so it's recorded instead. But thanks for watching, and stay safe on your next shift.